So hi everyone, my name is Hossam. I'm a third year medical student, and I actually see a lot of you guys. So I think immunology is a bit struggle for you, but inshallah it's going to be easy. It's always a repeated concept. You will find the same concepts again in year 2 and year 3. Okay, so let's start. And before I start, actually, I want to say something important. Usually, the names in immunology sometimes solve the case. So if I say membrane attack complex, what does it do? It attacks the membrane easily, right? So that's an example. So let's see what we have. Right. First of all, you need to know that immune system is not an organ-based system. It's not a stomach, a heart, intestine. No, it's a cell-based system. What does it mean? Usually, the main players or main components of the immune system is cells. Okay, and what the organs that synthesize these cells is the bone marrow. Actually, they are white blood cells. Okay, so they are a component of blood. And what makes the blood? Again, it's bone marrow. And actually, we have two cells in the bone marrow. You have the lymphoid progenitor and the myeloid progenitor. The myeloid progenitor actually make most of the blood cells, the RBCs and the platelets, okay, and other immune cells, which are the granulocytes, which I call them BENs, okay, B-E-N, the basophils, eosinophils, and neutrophils. Okay, also they make monocytes, and monocytes is the macrophages. Okay, and we have a variant of the macrophages called dendritic cell. They are simply cousins, and we'll talk about each one specifically and what is their function. And we have the lymphoid progenitor. From its name, it makes what? Lymphocytes. Yeah, exactly. Lymphocyte, P lymphocyte, T lymphocyte. And we have several subclassification of T lymphocytes, such as helper T cells, cytotoxic T cell, and a memory T cell. And we will know specifically which one is responsible for what. Right. So, as I said, the synthesis of the manufacturing of WBCs happens in the bone marrow. Right. We have then the primary lymphoid organs and the secondary lymphoid organs. They have a different job. Okay, the synthesis in bone marrow, but the lymphoid organs, especially the primary lymphoid organs, they are where the maturation and further development occurs. And what are these primary lymphoid organs? The bone marrow is one of them, and thymus. And the thymus, the function of it, it's for the location where T cell matures after it synthesized in the bone marrow, and the B cell mature again in the bone marrow. Okay. So then we have the secondary lymphoid organs. We cannot let these WBCs or white blood cell traveling in the blood and in the body without doing anything. Okay, otherwise it can cause inflammation, unwanted inflammation. So what do we need? A place to accommodate these WBCs. Okay, especially the lymphocytes. And I do mean. So we have the secondary lymphoid organs. For an example, we have the lymph nodes, the spleen, and the mucosal associated lymphoid tissue. They are where the lymphocytes resides. Okay. So again, if there's a question about the location of the maturation of T lymphocytes, what will be the answer? Times, exactly. Type. If I am a pathogen and I need to invade a system, and our human, there is a sum of the lines, defense lines, I might encounter. The first line is the anatomic barriers. What are the anatomic barriers? There are skin, the oval mucosa, the respiratory epithelium, the intestine. Basically, they are the outer lining of the organs and the skin. Okay, and the complement and the antimicrobial proteins, they are found in the mucosa and the blood. The blood is found in the complement. We will talk especially about it in different slides. And the innate immune system. All of the above, except the adaptive immunity, are part of the innate immune system. Okay, so the skin is actually part of the innate immune system. The complement is part of innate immune system, and the other arm of the immune system is the adaptive immunity. Okay, it consists of B cells and T cells. Right. First of all, if I ask you a question about what is the first line defense mechanism, exactly, it will be the skin, the mucosa, and respiratory epithelium. Every barrier that's breached, the other one will get activated. Okay, so it's not like when I get a pathogen, adaptive will activate first. No, there is a line that needs to be breached. After the pathogen will break the skin, the complements will get activated. After it gets activated, and if it doesn't kill the pathogen, again the innate immune cells will get involved. If it's not, and will be the last defensive system, which will be the adaptive immunity. Okay. So we need to differentiate between the innate immune cells and the adaptive immune cells. Okay, we have the innate immunity. We have the macrophages. Again, the granulocytes of the PENs, P-E-N-S, P-E-N, the basophils, eosinophils, and neutrophils. And we have the natural killer cell, and we will talk specifically about it. I don't want to jump on things. And in the adaptive immunity, you have the B cell and the antibodies. You have the T cells also, and its sub-classifications. Type 100% or 110%, there will be a question about the difference between innate and adaptive immunity. Okay? So first of all, we need to know that innate immunity is fast, work within hours, 6 to 12 hours maximum. It's not specific. What do I mean by this is any pathogen, it doesn't differentiate between anything, virus, bacteria, parasite, anything, it will do the same mechanism to fight. It's not specific. It recognizes antigen directly, it doesn't need any antigen presenting cells, and I'll explain what is it. And also we have it always reset to the baseline, or it has no memory, okay? And we'll talk about it also in details. The adaptive immunity, however, it's actually slow. It's very specific. Every cell in the adaptive immunity, so B cell or T lymphocyte, it has a certain role in a certain pathogen. يعني مثلا, for example, TB is a type of bacteria. It has a certain T lymphocyte to attack. Okay, and for example, the T cells in the adaptive immunity, it cannot detect pathogen by itself. It needs an antigen presenting cells. And we need to know what are those, and we will speak about it. And again, with what is characteristic of adaptive immunity, it has a memory. Okay, so if I get infected again, will be the same reaction, or would be, yeah, exactly, better. We'll talk about it also in details. Type, regulation of immune cells function. Type, first of all, when a pathogen enters our systems, what we have is a sensor cells, or we call it a sentinel cells. They are the macrophages and the dendritic cells, okay? They usually are always in a constant surveillance. They are traveling, searching for pathogens everywhere in the body. Okay, once they found one and they capture it, they release a cytokines and chemokines, which called the mediators. And what are those mediators? They are actually a communication way between cells and each other. They have a language, okay? So, and when I want to talk about the difference between chemokines and chemokines actually, they are attractants. We call it interchangeably chemoattractants, okay? So they recruit more effectors or more cells to come to the place of the infection. And also we have the cytokines, they act on the effectors by itself, like it may cause a vasodilation or maybe cause an inflammatory response more than powerful than without them, okay? Type. Types of adaptive immunity, we have two classifications of adaptive immunity. We have the humoral one and the cell-mediated. Okay. The humoral one, actually, it's not cell-mediated. Why? Because the main effector is the antibody. And the antibody is secreted by what? B cells. Okay? So humoral immunity always associated with B cells. However, cell-mediated immunity is always associated with T cells. Exactly. Right. We have different scenarios. If it's extracellular microbes, the humoral immunity will get activated. Okay? The B lymphocyte will release antibodies, and these antibodies will neutralize and block further infection of the antigen. Type. If we have a microbe that's phagocytosed, there are some microbes that can be phagocytosed and not be destroyed, like TB, and we will talk about it. TB can reside in the macrophages and cannot be destroyed. So what will happen? Actually, we have the T helper cell, again, is a part of cell-mediated immunity. It makes the macrophages stronger so it can destroy the infection. Right. The other way we have, if it's an intracellular microbe such as viruses, what will happen? We have the other T lymphocyte, which is the cytotoxic T lymphocyte. It will kill the cell with the virus. It will not eradicate the virus by itself. It kills the infected cells with it. Okay. Type. When I'm talking about the memory, there is something you need to know. Like, let's take an example about the B cell condition. If I have an infection, first infection of maybe a bacteria, okay? What happens is that the B cell gets activated, okay? And when it gets activated, it releases short-lived plasma cells. Plasma cells is a differentiation of B cells. It releases the antibodies, okay? It releases antibodies. And the first infection, the most prominent antibodies that is secreted is the IgM and IgG, but IgM mainly. In the second infection, however, we can find that the memory cell, the most predominant antibody is IgG, and we will talk about the class switching and how does it happen. Type. Do you guys see what is the difference between the first and the second exposure to an infection? What happens is it took to reach the peak response mainly a week, okay, in the first exposure. But we can see in the second exposure, it only takes 3 days, so it's faster, right? So again, the secondary exposure to an infection, after we have a memory cell, we will be having a faster response and actually a larger response. Why? Because in the first exposure, some of the B cells became memory cells, okay? So they are residing there waiting for the same infection to come again. Okay, so after the first infection, I build up some memory cells. So in the second infection, I have more B cells attacking the same pathogen. So in the secondary exposure, what happened will be, it will be faster and it will be stronger immunity, okay? And this is actually the principles behind vaccines. We give vaccines, dead virus, so of the bacteria, to make immunity and memory cells fighting it. Type. The life history of a lymphocyte, as I said, the B lymphocyte, it can recognize antigen directly. However, T lymphocyte needs an antigen-presenting cell, and we will talk about it. And after it gets activated, it proliferates, means in number, and differentiate into plasma cells, and some of them make memory cells. The plasma cells is the one that releases antibody. And in the T lymphocytes, it will proliferate, and some of them will release cytokines, and some of them will become cytotoxic T cells for another infection. Type. Here's some of the question you can find. Type. What is the which of the following is considered a primary lymphoid organ? Thymus. So, what type of immune response involves antibodies? Humoral immunity. Which cells are primarily responsible for the adaptive immunity? P and T lymphocyte, exactly. What is the role of antigen-presenting cells? From the name, it's to present antigen to T cells. B cells can recognize antigen directly, okay? That's what I'm... Right. Which of the following cell is key component of the innate immune system? C, neutrophils, actually. Right. What do memory cells do? Exactly. And which of the following is a characteristic of adaptive immunity? Memory formation. Non-specific is innate. Immediate response is also innate. Physical barriers is also the innate part of the skin. Cytokines are important in the immune response because بالضبط. Cytokines and chemokines, they are the language between cells to communicate with each other. The second lecture, the first lecture was introduction to the immunity in general. Now we will talk a little bit more details about the innate immunity. The innate immune response, as we said, it's the initial responses to microbes and also injured tissue and dead cells. Because the immune system also not fighting only pathogens or bacteria or viruses, it also fight dead cells, cancer cells also, okay? So, and also it stimulates adaptive immunity when it's reached. Right. The general features of innate immunity, this is need to be known by heart, okay? 100% هيجي question about the difference between innate and adaptive immunity. It's the first arm to get activated. Cells are able to recognize antigen directly, doesn't need any antigen-presenting cells. It's fast, non-specific, and reset to the baseline of no memory, okay? Right. What are the sense of cells we talked about? Macrophages and dendritic cells. They are always in a state of surveillance. They are searching for a pathogen to capture. So when they capture a pathogen, what will happen? They release cytokines and chemokines. And these cytokines, chemokines, what they do is again they recruit more WBCs by inflammation. So again, if there is any infection, there is need to be an inflammation. Why? Okay. So first of all, the inflammation makes the blood vessels, vasodilation. Blood vessels become more leaky. And why do they become leaky? So the WBCs gets out and go to the site of infection to fight the pathogen. Okay? And also not only the WBCs can get escape, also there is proteins and fluid that causes what? Edema. Exactly. Type. We talked about the innate immune cells, which are the macrophages, which are the granulocytes, the complement proteins, and dendritic cells. We will talk especially about everyone in its case. So we have macrophages has 3 scenarios to control the infection. Okay, the first scenario, if the pathogen is actually weak, okay, so it captures it, engulfs, phagocytoses it. It's very smooth, very easily. it doesn't do anything, or it's not hard to kill it. If the pathogen is a little bit virulent, what will happen? It needs more help. Okay, so what happens? It will call for neutrophils. Neutrophils is the same as macrophages. It phagocytizes the pathogen, but it's more stronger. Okay, right. How they can call for the neutrophils again? By cytokines. Which one especially? We have the IL-8, interleukin 8. Okay, one way to remember it is the nucleus of neutrophils appears like an 8. Okay, so it recalls IL-8. Right. The third scenario, if the pathogen is more stronger and stronger, and phagocytes cannot kill it, what happens is it calls for another cells, not neutrophils this time. It calls for T helper cells. Okay, and T helper cells, it calls it by IL-12, and T helper cells, when it releases again another cytokine, which is the interferon gamma. Okay, the interferon gamma results in the macrophages to be stronger. Okay, so they can kill the pathogen easily. This is the way the macrophages can kill a pathogen. Okay, three scenarios: if it's a low virulence or weak, if it's an intermediate weakness, if it's so strong, what will happen? Okay, type. The dendritic cell is the most efficient antigen-presenting cell. It's the most important one, and it's the bridge between innate immunity and adaptive immunity. Okay, if the innate immunity breached, the adaptive immunity will get involved by dendritic cells. Okay, it has subsets, which is the classical one located in the epithelia. تفضل. خلاص ما في مشكله تمام. لا هي الفكره بس ان انا كنت اقول located in epithelia. Why? It should be near the entrance of the pathogen. Okay, so it cannot be floating in the body as easily. طيب الامmature والmature. Immature dendritic cells, it actually has a different role than presenting the antigen to a T cell. What it does, it is have a role in presentation of self-antigen and maintenance of tolerance. You will learn about tolerance in maybe the next weeks or maybe the second semester. It's a way of educating the immune system to not attack my body. Okay, otherwise it can cause autoimmune diseases. Okay, so immature dendritic cells are involved in maintenance of tolerance. The mature one is the one we know. Okay, it presents the antigen to the lymphocytes. Type. Here's an example. The dendritic cell, which is in the epithelia, captured an antigen. It goes through the lymph organs, the secondary lymph organs, to the lymph nodes. As I said, lymph nodes. What's the function of lymph nodes? It's the place that accommodates the T lymphocyte and B lymphocyte. Okay, it's a secondary lymphoid organs as we took. Type. What happens? It scans for the specific T lymphocyte that can kill this pathogen. Like if I have a key and I don't know this key, what door it opens. So I try several doors, right? Till I find the one. This is the same mechanism. It goes to the lymph node, searching for the T lymphocyte that's specific for this antigen that can kill it. طيب. حلو. طيب. How does this happen? يعني dendritic cells, we said it captures the antigen. How? Based on what it captures the antigen? It actually recognizes what we call a pathogen-associated molecular patterns, PAMPs. And again, as the name indicates, always the name solves the case. Okay, as the name indicates, it is the pathogen. It's a hallmark, or it's a symbol that's found in the pathogen that tells the dendritic cell this is a pathogen. Okay, and the DAMPs, or damage-associated molecular pattern, is the same thing. It's just a symbol, found in the dying cells that says, for the dendritic cells to capture it. Okay. Type. How does the antigen-presenting cell or the dendritic cell catches the PAMPs or the DAMPs? We have what we call cellular pattern recognition receptor. Okay. اللي هم مين toll-like receptor, the C-type lectin receptor, the node-like receptor, the reg-like receptor. You need to know this, guys. Okay. And there was a question in the previous. They are asking about what type of cellular pattern recognition receptor inside an endosome. It was toll-like receptor. طيب. So الcellular pattern recognition receptor, it detects PAMPs and DAMPs. صح؟ طيب. When we talk about toll-like receptor, it's found in the extracellular and the endosome. طيب. If I asked about C-type lectin receptor, it's for fungi. Okay. If I asked about viruses actually gets into the bacteria, in the cytosol of the bacteria. If I'm asking about viruses, it will be reg-like receptor. and the node-like receptor for intracellular bacteria and the cell damage, tissue damage and the type. The dendritic cell captures the antigen already. Okay, the خلاص toll-like receptor, it gets it and engulfs the pathogen. Okay, what will happen? It will process the antigen and presenting in what? MHC class. Okay, MHC is just a receptor that carries the antigen on its surface. Okay, to give it to the T cell. Okay, what happens is actually we need two signals so the T cell can get activated. Right, the first signal again is the MHC with the T cell receptor, TCR. Okay. The first signal is like saying the dendritic cell saying, please kill this antigen. Okay. Whether we need a second signal, okay, which is the B7C28, you will get a question about this. It's so important, okay? Which basically is saying that T cell is saying, are you sure? Do you want me to kill this antigen? It will say yes, okay? So this is the second signal. Without the second signal of the co-stimulatory signal, it will not get activated. The T cell will go in anergy. Anergy means deactivation. It will not work. It will not kill any pathogen. So we need two signals. First one is B7CD28. Okay. طيب خلصنا dendritic cells. Now we will talk about natural killer cells. Natural killer cells actually they are a T lymphocyte. Someone will ask me how T lymphocyte is a part of the innate system. They are a specifically T lymphocyte that works in innate because they are non-specific. They are non-specific. As we took that innate is not specific. Like in the other T lymphocytes, B lymphocytes, they have every antigen, it has a certain T lymphocyte. So they kill anything. So it's non-specific, so it's innate. Right. How do they kill the pathogen? By releasing performance and other cytolytic chemicals. We will know about it later. Right. They also work in against the cancer cell and virus-infected cells. Okay, this is an important information. They are the cancer cells and virus-infected cells. Right. How do they recognize that this cell needs to be destroyed? Right. The viruses of the cancer cells, they think they are smart. They found that if the dendritic cell presenting MHC class, I will destroy it. صح? But what will happen? I will remove this MHC class. So nobody will gonna know that's me, that I'm a virus infected cell. What will happen is the natural killer cell is actually gets activated when this happens. The absence of MHC class will activate the natural killer cell, so it can kill the cell that is infected by a virus or if it's a cancer cell. خلاص? Everything is clear till now?
So I thought it was talking about natural killer cells. They degrade the MSG.
No, the virus or the cancer cell, they change itself. So they remove it. They do not express it anymore. Like they hide it. Okay? So because they don't want to be killed by T cell. So when it does happen, the absence of MHC class will cause the natural cell to get activated and kills the cell. But the xenophils, actually xenophils, it's so short, it's fights parasites and allergens. Okay, so if there's a question about what is the cells that involved in allergy, it's going to be a xenophil. Okay, it kills using not performance, hydrogen peroxide, and superoxide, which are type of bleach, chlorine. Okay, the basophils is actually cells that contains important granules for that aid mobility of the WBCs. What do I mean by this? We took that the macrophages sometimes release cytokines and chemokines to cause vasodilation. So there will be the more phagocytes or more cells can go to the site of the infection. So the same concept happens here. Leukotriene means histamine and heparin. You need to know, guys, which one. Okay, heparin inhibits the formation of clots. Why? Because clots can impair the movement of WBCs. Right. Histamine is a vasodilator. Again, vasodilation is important, so the blood vessel gets leaky and WBCs can get out of it, the blood vessel and gets to the tissue. And leukotrienes attract neutrophils and xenophils. Mast cells is the same as basophils, but in a different location. Basophils are found in blood. Mast cells are found in the tissue. Right. We said the heparin and the leukotrienes is found in the granules. صح? We need a degranulation process. We need this granule to pop up so the mediators can get out. How does this happen? It's actually respond to IgE, which is an immunoglobulin E. And when the basophil attached to the Fc epsilon part in the IgE, it gets released the histamine and the heparin and all the leukotrienes. Okay, it's part of the IgE. Right, the complement system. When we talk about the complement system, is found in the blood. Right, in the serum of proteins, or yani means in the blood. They are a cascade. Cascade means like they are a step over step over step over step. Okay, it's a 25 step, but all we need to know is the function. It has two functions. Okay, the first function is opsonization, which is tagging the pathogen of the cell that is infected to be killed. Okay, and the other one is actually recruiting phagocytes. طيب حلو. طيب the complement system gets activated by three ways: lectin pathway, classical pathway, and the third way is alternative pathway. طيب how does it get activated? It's not important. Okay, حتى في مربع احمر كبير عندكم في الباوربوينت يعني. طيب what happens is the end product of these three ways is the same. Okay, it's the same. So it gets what C3 convertase and C5 convertase gets activated. Type the C3 convertase, what does it do? It cleaves the C3 into C3A and C3B, and the same as C5 convertase, C5A, C5B. Help? Okay. From its name, A stands for attraction. Okay. So C3A, C3, and C5A is attracting neutrophils and macrophages to the site of infection. Okay. And C3b is used actually for the opsonization, which is tagging the pathogen to get phagocytosed, to get attacked. Okay. The C5b, however, what does it do? It forms formation of the MAC, which is MAC, membrane attack complex. From its name, what does it do? Yes, it attacks the membrane of the pathogen, causing a lysis. This is the complement pathway. But here's the question. Okay. يلا what is the role of natural killer cells؟ أنا حطيت الأنسر. خلاص be honest with yourself, okay? Yeah. Which of the following components is not part of the innate immune system? So antibodies, صح? Antibodies is part of which part of the adaptive? B cell أو the humoral immunity, صح؟ طيب which type of receptor in immune cells recognize the BAMs? Toll-like receptors. The extracellular toll-like receptor, endosomal toll-like receptor. The fungal one? C-type, C-type. And for the tissue damage? Not for the viruses? Like acid.
Which part recognize the dumps?
ما هي دامب زي نفسها اسمها ايه؟ بود لايك ولا نوت لايك؟ نوت لايك ريسبتور. طيب which of the following complement components for the membrane attack complex? طيب الكاسكيد نفسه it's not important بس ل C1 it's not involved in the I said start with C5B صح؟ ف it's center of C. Which of the following is a major effect of C3B in the complement system? Opsonization. Okay. طب what about C3A? C5A. تفضل. اكيد. اي نعم. ايه toll like receptor. بشرح لك الحين. طيب احنا قلنا البامبس is just a symbol that is found in the pathogens, okay, that says the dendritic cells I'm a pathogen, okay, so please engulf me. Right, the how does it engulf the dendritic cell? How does it engulf the pathogen of the PAMs? By toll-like receptor. So it recognizes the pathogen by the toll-like receptor. Okay. Depends on the pathogen itself. If it's CLR, it will be what? Fungal, not a bacterial. Okay. لا بس يعني هنا الباقي كله غلط. اللي مش سي مولكيول it's not a way to recognize it. تمام. التي سيل ريسبتور the same. بي سيل ريسبتور لا. So toll-like receptor يعني if there is مثلا an answer that's C type it would be right لأن I didn't specify it if it's a fungal or a bacterial. فهمت علي؟ طيب the third lecture which is the adaptive immune system. تفضل. The BAMs لا depends. Okay. طيب let's say this is a pathogen, okay? The pathogen is having what? The BAM, okay? It doesn't matter if it's a fungi or bacteria or something, okay? Then I have the dendritic cells. Okay, dendritic cells. It does what having the cellular pattern recognition receptor, okay? It depends, it could be toll-like receptor, okay? It could be CLR. طيب it could be inside تمام اللي هي النود لايك وcould be الريج. طيب this TLR recognize the BAMPs, okay? Even the CLR, the node like, all of them recognize the BAMPs, okay? But it differs in the pathogen. Toll-like receptor recognize the BAMPs on bacteria, okay? It's bacteria. The CLR on fungus. طيب if it's after engulfing the pathogen, طيب if it's a virus, the virus would be by the reg-like. If it's a tissue damage, it will be recognized by the node, okay? That's it. فهمت؟ ولا عيدها؟ ما عنديش مشكلة، أنا قاعد بالليل.
عندي سؤال.
اتفضل.
ليش يسوي لها انجلف اذا ما سوى لها يعني مثلا دامج سيل انجلف and then it detects it would be known.
ايوه.
Why does it engulf it?
مش فاهم عليك سؤال معلش ممكن.
النود انجلف.
اي.
دامج سيل صح؟
detects damage to cells.
كيف هو يعمل يعني الدندريتك سيل why does it engulf a damage cell if it's still didn't detect؟
هو ريسبتور جوا كيف اذا السيل دامج الدندريتك حتعرف يعني
ما هي مثلا عندي لما يحصل سيل دامج بيكون fragments of the cells. طيب dendritic cells what does it go? It goes to engulf it. حلو؟
ليش انجلف اصلا؟
ليش انجلف بالاساس؟
بس المفروض ما يكون فيها الشغلات ثغرات موجوده بالجسم.
ايوه لان
هي عمليه تنظيف، مع عمليه التنظيف بتسوي لك ريكوجنيشن. يعني انت جيت تنظف بالمكنسه بعدين انت اخر التكنيك تفتح الباب تشوف انت شو نظف. نفس الفكره يعني انه انت
يعني شيء لا يحطيها ام سي ويز قبل
بالضبط. اذا في
بالضبط.
باثوجين قول للجماعه
الصوت مزعج ها؟
هو ايه تي سي ار بالظبط يعني؟
T cell receptor.
Yeah, it's for the like the MHC one with like CD8.
ايوه. It will come now, okay? بس ال MHC is for the T cell receptor. The different type of MHC we'll talk about now. Okay, يعني استعجلش. طيب. طيب ايوه. Okay. Now the adaptive immune system in details. The adaptive immune system قلنا consists of what؟ بسرعة يلا. T lymphocytes, B lymphocytes صح؟ طيب T lymphocyte, B lymphocyte resides where؟ بالضبط secondary lymphoid organs. حلو؟ طيب. That's it يعني basically about the introduction. طيب T lymphocytes قال لك في منها different types. في T helper cells، في cytotoxic T cells صح؟ طيب. When we talk about the CD is actually like tagging. يعني I know Rashid, it's Rashid because it's T-shaped. Okay? Same thing in the CD. CD4 is T helper cell. CD8 is cytotoxic T cell. That's it basically يعني تمام. ف they are actually like a tag for the cells. طيب when we talk about the T cell receptors, okay, it detects what? Or it connects with what? MHC. طيب سواء MHC class 1 class 2 we'll learn about them بس TCR always connect with the MHC class. okay. ال MHC موجود وين؟ على الانتيجين presenting cells. مش دايما على all nucleated cells and we'll talk specifically about it. طيب we have two types of MHC molecules which is okay. MHC1 is found in all nucleated cells. حتى الانتيجين presenting cells they have MHC class 1. طيب MHC class 2 is found only where? Antigen presenting cells which are the dendritic cells, the macrophages and the B cells. مظبوط؟ طيب what happens is CD1 goes to CD8 عفوا شو MHC1 CD8 اللي هم مين؟ سيتوتوكسيك تي سيل. طيب اما الام سي كلاس 2
دكتور على السبوره عادي.
انا بكتب انا بعمل ايه؟
عادي.
اصلا ما اعرفش بصراحه استعملها يعني. for CD what? CD4 cells. تمام؟ This is دايما MHC class 1. طيب if I want to destroy the cells and recruiting cytotoxic T cell منطقيا ممكن احطها على which MHC 1. T helper cell وظيفتها شو؟ انها بتساعد ال other cells. Okay? So it's found only the MHC class 2. It's only found in the antigen presenting cells. Okay? طيب طيب نتكلم دلوقتي عن different types of the T cells. We have the cytotoxic T cell. It's activated via antigen presenting on what? MHC class 1. Induce apoptosis of virus infected cell or malignant cell. This will be a question in the exam and will يعني see that I told you يعني I will tell you. طيب virus infected cell and malignant cells. Okay. طيب it releases the granules that contain performance and granzyme B. شبه مين؟ natural killer cell which are a T lymphocyte but is in the innate system. طيب clinical relevance involved in organ rejection. It's also the main contributor in organ rejection and donor graft cells rejection. Okay. طيب اما CD4 T cells it activated via MHC class what? 2. طيب it have subclassification. You have TH1, you have TH2 cells. طيب TH1 actually it's from immune response to intracellular pathogens such as the viruses and intracellular bacteria. This is what we talked about the macrophages. Remember when we told you that macrophages calls for T helper cell by IL-12, تمام? And the T helper cell release interferon what? Gamma to make the macrophages stronger. صح? This is the same principle. It helped the cells to kill intracellular pathogens. Macrophages, cytotoxic T cell, it makes them more stronger. Okay? The clinical relevance, it's important in TB because TB resides in phagocytes and macrophages, so it needs the macrophages to be stronger. Then we have the TH2 cell, it's for extracellular pathogen. It's mainly the activator of B cells, and we will know what does it mean later. But TH2 activating of B cells. طيب why does it activate B cells؟ لأن B cells هي اللي بتفايت الاكستراسيلولار باثوجين البكتيريا والباراسايتس والالرجنز. تمام؟ أحس إن أنتوا تهتم منه فخليني أعيد. طيب قلنا we have two types of MHC class molecules صح؟ class 1 class 2. MHC class 1 found in all nucleated cells حتى الانتيجين presenting cells. class 2 only found in the antigen presenting cells. تمام؟ قلنا cytotoxic T cell أو CD8 gets activated by MHC class 1. طيب MHC class 1. What is the function of it? It kills the cell with the infection. Okay? By performance and granzymes. It's so important in virus infected cell and malignant cells. Okay? It's also involved in organ rejection. طيب we have the T helper cell. T helper cell, the function of it من اسمها it helps other cells to kill the infection. Okay? We have two types, TH1, TH2. TH1 is for intracellular pathogens. تمام? We talk about it release cytokine that stimulate macrophages, cytotoxic T cell, natural killer cells. زي cytokines, what is the cytokines it releases? Interferon gamma. تمام? It makes the macrophages more stronger. تمام? Where we can find this situation? In TB. Why? Because TB can live inside the macrophages. So to kill it, it needs to be stronger. طيب TH2 cells, it activates the B cells. طيب why does it activate the B cells? بسبب ان البي cells is the main cell to fight the extracellular pathogens اللي هم البكتيريا والباراسايتس والالرجنز. Okay? So it releases cytokines which stimulate eosinophil, basophil and mast cells. طيب antigen presentation by dendritic cell. طيب إذا قلنا exogenous antigen are presented via MHC class 2. تمام؟ خلينا أشرح لكم بشكل أحسن. طيب قلنا الاكسجينس. تمام؟ who fights the exogenous؟ B cell. أحسنتي. طيب B cell. طيب البي سيل needs an activation by TH2 TH what 2 صح. So to activate TH2 should I present the antigen in MHC class 1 and MHC class 2 بالضبط. So the exogenous antigen, the dendritic cell present exogenous antigen on MHC class 2. Why? So it gets the B cell gets activated to kill it. Okay. اما اذا كان endogenous antigen it will be presented via MHC class 1. Why? To activate cytotoxic T cell so it can kill the cell with the infection. Okay. طيب remember we talked about the co-stimulatory signal? It is the same here. Okay. We need the first signal, which is the MHC and TCR, and the second signal, which is, are you sure they want me to kill it? Which is the B7 CD28. مظبوط? If the second signal is absent, the T cell will get into an AFG. It will be deactivated. It will not work. Okay. Right. B lymphocytes, the key cell in humoral immunity, we talk about it, reduce what? Immunoglobulins, which is the antibodies. It's the same. Okay. The surface of B lymphocytes are actually the immunoglobulins, IgM and IgD. طيب بس يعني it gets activated by TH2 cells. Okay, it releases antibody. We have different types of antibodies. We have 5 classifications. Okay. مجدي بالظبط. M A G D E. Okay. مجدي. M is a pentad, 5 antibodies together. A is a dimer, 2 antibodies together. Okay. Each one has a different role. Okay. IgM is in complement activation type, which is the most important in first exposure to an infection. Okay. طيب IgG للcomplement. Okay. أحسنت. وكمان هي the most abundant in the blood. طيب IgE is actually against helminth, which are parasites. Okay. And mast cell degranulation, as we said, صح? We said it before. Mast cell degranulation. It needs IgE مع FC epsilon, صح? طيب IgA is in what we call the fluid. Okay. It's found in the mucosa. Secretions بالضبط. طيب.
Let's wait for this slide. But to help you guys memorize this على السريع, let's give it some clinical relevance. But يعني for example, if I'm expecting to see a patient who has multiple upper respiratory infections, يعني دائما his chest is infected, his nose is infected, his mouth is infected, which of these IgEs would I expect that he wouldn't have? IgA. This is how we work with it, and this is actually a disease known as A immunoglobulin. But there's no immunoglobulins for IgA, and these patients we expect their GI tract, which is filled with mucosal layer, their upper respiratory tract, which is filled with mucosal layer, is always infected. They always come back infected. But this raises the suspicion that their IgAs is not there. This is for IgA. For IgE, the simple cases that we see in the hospital is allergy. Guy eats a peanut, he becomes red to flushed to he cannot breathe. This is typical case of what happens with IgE. طبعا the other thing is it helps against helminths, which is just a type of
parasites.
I mean, it's just a type of bug. نفس البكتيريا or virus. For IgD and IgM, صراحة I think IgD was the one that crosses the placenta.
أيوة IgD. So this is important.
Focus on this كمان. IgD is the one that crosses the placenta. Finally, IgG and IgM صراحة احنا بنحبهم كثير بعين مكتوب ليه؟ Because they tell us when an infection is either early or خلاص it's done. What do I mean by that? Which comes first, IgM or IgG? And then what comes after that? IgG. Because this happens, if I see مثلا طبعا there is IgG and IgM تقريبا لأي infection. You have an infection حيكون عندك IgG of that infection and IgM of that infection. إذا أنا مسكت البيشنت طيب قال لي he has an infection وشفت إنه he has the IgG of that infection. Is he in the early stage or the late stage? طبعا vice versa. This is clinical relevancy to why we study the immunoglobulins in this stage. I hope you guys understood يعني من ناحية طبية why we use this and why we learn this. Because it looks useless, but it's actually very useful.
Yes. تفضلي.
Why is there no IgG?
Well,
D is actually يعني it has no clinical relevance. Yeah. The B cell يعني. It's not important يعني.
لا بعرف الناس بتحضر لها تفاصيل.
طيب, we need to know the structure of this antibody, okay? And actually, the antibody detects what the epitope of the antigen. Okay, this is might be a question in the exam. This is the antigen, has an epitope. Okay, what detects the epitope is the variable region of the antibody. Okay, so what gets detected on the antigen? Epitope. What detects it and the antibody? Variable region. تمام؟
Question on IgE. So the FcRI, is it part of the IgE or is it separate?
Yeah, I know what are you talking about because it's written that it's found the Fc epsilon part is on it's in the mast cell itself. It's when it's attached to the IgE, it gets decvanulated. Okay, this is a way of, but other resources say the mast cell attached to the Fc epsilon part, which is in the end of the antibody. Let's stick to the slides, okay? And I would prefer to stick to the slides. طيب, the B lymphocytes, تمام, when it's developed, it's the plasma cells, and it releases what? Antibodies, or the immunoglobulins, صح؟ اللي هم IgM و A و G و E و D. طيب, the memory B cells persist in the secondary lymphoid organs, blah blah blah, كلام كله مش فاضي يعني, ما لناش دعوه بيه. تمام, هنا المهم.
لا هو لحد هون مو داخل كمل شرح.
والله مش داخل؟
لا لحد هون.
اما احسن لكم خلاص.
كمل عشان احنا ما يتراكم علينا يعني.
خلاص تمام, بكمل لكم, هي اخر تقريبا 2 to 3 slides. طيب, we have the activation of the B cells. طيب, the activation of B cells, it has two ways. T cell dependent, T cell independent. Again, as the name indicates, T cell dependent activation, it needs what? T cell. Which type of T cells? Which type of helper? Th2 cells, okay? And the T cell independent, it does not need any T cell to get activated. طيب, السؤال هنا, B lymphocyte needs an antigen presenting cell? No. طيب.
B lymphocyte itself is an antigen.
Is actually, صح كلامك. It's طيب, we have the T cell dependent. How does it يعني how does it work? How does the activation work? Okay. طيب, now I get infected by an antigen. The B cell detects this antigen, okay? It will go to the secondary lymphoid organs to search for a T lymphocyte that's specific, T helper cell, that's specific for this antigen, okay? The T helper cell will cause what? And proliferation and differentiation of the B cells, okay? So they can fight the infection. This was a question in our previous. They asked which type of cells help the differentiation of and the proliferation of B cells and the extracellular effects. Yeah, T helper cells or Th2 cells. أما إذا كانت independent, it does not need an T helper cell, which will be in this case, the antigen itself is so big, okay, that it can cause cross-linking of two receptors on the B cells. So it doesn't need any activation or help from T helper cells. And طبعا the T cell dependent antigens, تمام, what's the يعني why is it so important? Because it's the way of that produces long-term memory. طيب, إذا كانت independent, it does not produce any memory. تمام. There's isotype switching, which classes, as Rashid said, IgM the first exposure. Okay. When the exposure resolves, what will happen is this IgM will turn into IgG. Okay. So again, early stage, later stage. Early stage will be IgM, later stage will be IgE. How does it switch? This is what we call it isotype switching. There's a cytokine that's released by T helper cells that cause the class switching from IgM to IgG. بالضبط كده. And I think this is the question part. يلا. What? Oh الله. مشكلة. تعرف تشيلها يا راشد؟ طيب خليني أنا أسألهم من تليفوني.
انت شو البوظه اللي
خلاص ما دلوقتي طالعين.
يا حبيبي اهدى شوي انا يعني
انت صح, نسيتك والله, معلش. طيب, السؤال هنا without choices, okay? What is the primary characteristic of adaptive immunity?
اعطيهم choices.
Specificity and there is a memory. طيب. Which cells are primarily responsible for humoral immunity? B cells. Which part of the antigen is recognized by the immune system? epitope. تمام. How does it recognize it? Variable region on the antibody. طيب in cell mediated immunity, which cells directly destroy the infected host cell? ولا T helper cell؟ cytotoxic هتخليها تنخدعش. Which immunoglobulin is primarily responsible for allergic reactions? IgE. أي صح. طيب how do cytotoxic T cell kill infected cells? Granzymes, induce apoptosis by granzymes and performance. Okay, that's it. تفضل. Okay. ارجع كمان. هل لا. Why? Because it used T cell and B cell. فاهم علي؟ يعني إذا كانت innate صحيح إن innate doesn't produce any memory بس هنا في involvement of what? T cell. So this is makes it an adaptive immunity يعني بشكل عام. I hope I was يعني great at my explanation and متأكدين في حاجة مش فاهمينها؟ كله تمام؟ خلاص that's it. Thank you.
Take an hour, inshallah. Yeah.
شوي ايوه هيك بطاطا ما في شيء فيعني you skip you jump to the second half of the lecture that's genuinely where there's something to actually get something in the exam from يعني we start in the beginning of in the middle of the first lecture the doctor explains about the routes of drug administration. طيب in general, if you are pretty يعني familiar with drug administrations, if you've taken different type of drugs يعني أدوية مش drugs أدوية طيب there are two types of how you could يعني take them. We would say it's either systematic or topical. Let's explain topical قبل ما ندخل على systematic. Topical means إنه it covers the area of the problem. In other words, this is usually done in specific areas in the body. يعني for example, the eye, the ear, the skin. This is mainly the three things that we like to give topical treatment. ليش? Because first of all, one of the best things about topical treatment is it doesn't go around the whole body, and by that it doesn't cause systematic problems, adverse effects and side effects. ليش؟ عشان مثلا أنا عندي medication I want to give to my skin. The same medication if it reaches my liver حتسوي مصايب. طب أنا ليش أدخلها بالدم؟ وصح if I put it in the blood it's gonna reach the skin. It's gonna fix the problem, but at the same time, it's gonna go through the liver. So why do I have to go through that? لا خلاص, I'll just create a formula which allows me just to put it on my skin, fix the problem, and that's it. This is why we like topical treatment. The other reason we do that, for example, in the eye, the blood system of the eye مع the blood system of the body is sometimes not so matched. اللي هي, for example, if I put the same مثلا medication that fixes the problem in the eye into your blood, the blood system within the eye doesn't really, يعني, we would say, it doesn't really combine with the blood system that you have in the body. Therefore, the amount of drugs that reaches the eye is very little. So therefore, we're forced to, when fixing the problem in the eye, we have to give it topical. غير هيك, there are areas in the eye that are أصلاً bloodless, يعني ما عندهم blood supply. يعني سلم لي ما في شيء اسمه systemic for the eye. You have to go there specifically, put eye drops, for example. This is why there is something called eye drops. Because the eyes are not, and they're not supplied by blood. Therefore, systemically speaking, we cannot give it or give the medications through the blood. طيب واحد بيسأل Rashid, you keep saying blood. ليش عم تحكي blood? It's simply because this is the systematic route. يعني when we speak about systemic drug administration, it means إنه the drug reached the blood and from there it went to the area that it has to fix. طيب to go over very simple concepts, what is the word that we give to the amount of drug that has reached the blood? Yes, bioavailability. طيب طبعا we're going to talk about mainly what it means and why is it important and how different routes in the systemic area اللي هي again it's related to the blood and the coverage of the drug within the blood system. طيب what it means for each of them من ناحية bioavailability وغير هيك. بس طبعا topical فهمنا فكرة topical, we understood what topical is. It's again you put the medication on top of whatever area you want to fix. طيب for systemic وعندنا enteral و parenteral. طبعا انا يعني till yesterday I understood the difference. I keep hearing it in the hospital. I never knew the difference. بس يعني it's a very stupid concept that I hate. But at the same time you want to know about it because يعني they do say it a lot in the hospital. They say parenteral, TPN. This just means no, the drug has been given, the medication has been given in other areas other than the two orifices اللي هي simply the GI tract. يعني whatever administration of drug I give that doesn't go through my GI tract, يعني the mouth, the esophagus, the stomach, the intestines, the colon, if it doesn't go through that means it went through parenteral ways. For example, IV. لما أنا أدخل أنبوب through my blood, when I put it inside my blood and the drug goes from the bag into the blood, in this way it did not go through what? The GI tract. But this is parenteral administration. Similarly, subcutaneous, similarly intramuscular صح. These three ways mainly are known as parenteral. معناتها it did not go through the GI tract. شو هم الانترال which are the ones that go through the GI tract اللي هي هاي. طيب they're the oral, sublingual and rectal. من الآخر هذول are three ways where we're putting it inside the GI tract for them to reach. شو في الآخر what's the end goal? The blood. بالآخر أنا if I'm gonna give a drug systemically I have to have it reach to الدم. من الدم حتروح على the area that it needs to go. طيب for the enteral as we said في عندنا oral. تقريبا all of us are familiar with oral drugs. What they do, they go into the GI tract, they get absorbed and then they get dealt with. Sublingual, تقريبا there is one very specific type of drug that is given sublingual. It's called nitroglycerin. It's called nitroglycerin. It is given in an MI case and it's very effective. It helps, أول شيء it bypasses the liver and we're going to talk about what that means. Second of all, that's better than that. Its effect is very quick. And I just said it, it's used in an MI case. What's MI? Myocardial infarction. طبعا when we think of MI, we think of, oh my God, this guy's going to die. This is why we do or give this drug sublingually because it gives a very fast effect. What does the drug do? It does two things. أول شيء, it relieves the heart from the pain of the MI, which is very severe. Second of all, it relieves what we call as the afterload, which is usually the reason يعني the heart is in a problematic issue. في الآخر هاي في الكارديو هنحكي عنها بعدين when you get to year 2. بس to make stuff simpler, this drug that we give nitroglycerin is very fast and it bypasses the liver. هنحكي عن bypassing the liver, why it is important in a bit. طيب؟ يعني بس كمان اسم دراج عادي يعني عوافي في ساينايد كمان. طيب for rectal this is why ليش ركضت؟ طيب for rectal it also bypasses the liver and the reason again we give rectal is because mainly it bypasses the liver. وحنحكي هلا why we care about the bypassing of the liver. إذا في شيء that we care about is when I give 100 milligrams of this drug, does the 100 milligram reach ولا لا؟ وطبعا this is what we just explained as in يعني is the concept of bioavailability. بس to be specific, bioavailability means كمية drugs that have went from one place into the blood. يعني for example أنا عندي 100 جرام جوا هالكيس بعدين I introduced it into my body in whatever way. I check the amount that is in my blood. For example, I found it's 30 milligram. This means in the bioavailability of this drug is how much? 30%. Hello? This is the first يعني barrier that the drug has to go through اللي هي the bioavailability problem اللي هي how much drug stays من لما تروح من whatever it is اللي هي within the packet into the blood. The second problem it faces is the liver. هذا هو البيج بوس اصلا يعني هو بس قاعد يستنى في الدرج يجي عشان يمسح فيه الارض. ليش؟ What the liver does is simply it clarifies يعني it cleans the blood from all the metabolites that is not really useful for the body. من ناحية useful I mean إنه it's not يعني usually it's not there. And for example, if you have a lot of fat in your blood, the liver takes care of it. بياخذها. If you have a lot of sugar, it takes it. If it has a lot of medications, it takes it. If it has a lot of toxins, it also takes it. And this is why usually in cases of intoxication, in case of high lipid amounts in your blood, the first organ to be hit is the liver. ليش؟ عشان هي it's the first line of defense in clearing out the metabolites and the problems that we see in the blood. Because of this very big advantage, منها بيجي disadvantage of what? Of when we take medications, the liver كمان حدبر أمرها معاهم إنه it's gonna clear it out. ف what we did as يعني إنه as مش إحنا طبعا pharmacists, what they did as pharmacists is they found out إنه by giving certain drugs, specifically these drugs that are very liable to liver metabolism, يعني هذول إذا مشوا بالليفر حيختفوا. يعني it's as if we never gave them. To help them we have to bypass them from the liver. يعني لازم احنا نحطهم جوا البلد بطريقه انه ما يمشوا من خلال الليفر. فواحد يحكي طب راشد ليش الليفر؟ يعني هو الليفر قاعد بنص البادي هيك قاعد بنص انه everything is gonna reach the liver in the end. Yes, everything تقريبا reaches the liver in the end. Why? Because of the portal vein that eventually reaches the liver and gets to everything cleared out. What I mean by that is simply is لما الانترال system takes in the drug and the drug is absorbed, it goes through the veins of the intestines, and من veins of the intestines it reaches the liver. تقريبا all of them. The only two places that doesn't reach this is the veins of the sublingual region and the veins of the rectal area. هذول الاثنين they do not reach to the liver. Actually this is كمان a fun fact. In what way? اللي هي when the liver actually dies, hello, all the blood that was supposed to go through the liver no more goes through the liver, it goes to everywhere else. يعني it goes through the route that doesn't go through the liver. يعني تاخذ طرق ثانيه زي مثلا الشارع الرئيسي سكر وهو شارع رئيسي هو الليفر، فلما الشارع الرئيسي سكر شو السيارات بتصير تسوي؟ تروح الشوارع الفرعيه. طبعا الشوارع الفرعيه بتصير هيك يعني it gets too overcrowded. نفس الشيء when this liver organ stops working, when the blood stops going through the liver, what happens to the blood? It goes through these same routes that we use to bypass it من ناحيه metabolism. فبالاخر if there's something you need to know يا جماعه it is sublingual and rectal. What does it do? It bypasses the liver. يعني تقريبا if there's gonna come a question from this lecture it comes from this concept. This is why I took a bit of time to explain it يعني. طيب for parenteral as we said شو فكرة الparenteral is it doesn't go through the GI tract أهم شيء. طيب we have transdermal injections and inhalations. طيب injections عندنا intravenous, intramuscular, subcutaneous بلا 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 في مليون نوع. في الآخر the concept is the same اللي هي إيش؟ It doesn't go through the GI tract. طيب okay for parenteral طيب for parenteral what is known about them is they are poorly absorbed أو they have 100% bioavailability, which is specifically which one? intravenous بالضبط. يعني they're either very bad at absorption أو they are يعني فل اللي هي intravenous. طيب بس with the poor absorption comes a very good advantage because they're poorly absorbed or حتى يعني better than the word poorly absorbed, they are slowly absorbed. This comes with an advantage من ناحية إيش؟ And this actually comes with the insulin injection specifically for the diabetes patients اللي هي when we give them subcutaneous injections. طيب طبعا يعني to go overview على السريع for the diabetes patients do not have sufficient insulin to help what? To help clear out the blood from glucose. طيب of course this insulin always rises up and down within their body throughout the whole day. فاحنا we want to replicate this system من ناحية drugs. فاحنا we cannot expect we cannot expect them to take every 10 minutes insulin injections or insulin أدوية. We have to find a system where this drug I give it once to them and this one time that I give it خلاص for the whole day it slowly releases into the blood and by that it contains a similar amount to that of which a normal person has اللي هي a steady amount of insulin that's always there. Similarly through parenteral injection especially subcutaneous and intramuscular the absorption is slow and therefore because it's slow the level of the drug in the blood maintains the same throughout the day. This is helped كتير in what specifically in diabetic patients. عشان هيك diabetic patients إذا بتلاحظوا their injections are either in the thigh, in the abdomen, around the umbilicus, طيب, or sometimes in the shoulder. هذول they're usually done because again the absorption is slow and it helps with maintaining the level of drug that we need. طيب again parenteral drugs, why are they not given كمان? Because they're unstable in acid and stomach. Parenteral زي ما حكينا it doesn't go through the GI. If we're not going to go through the GI, we need to make sure, and if we're going to go through the GI, we need to make sure and whatever I'm taking in has to be what, يعني it should be able to maintain the acidity in the stomach. If it doesn't نخليها parenteral، يعني هنحول الدرug formula ل parenteral administration. طيب طبعا all these are logical يعني ف I don't want to go over each of them. طيب بس يعني you understand the point. طيب اللي هي subcutaneous intramuscular which we're going to come in a bit about has slow absorption which helps in شو بالآخر maintaining the drug levels to be the same throughout the day. طيب it's slow absorption مش slow، يعني لا مش بطيء. انت الجي اتراك تبعك يعني انه مش slow absorption من ناحيه انه long release، slow absorption انه بيطول تا it gets absorbed. الانتراماسكولار and subcutaneous it's slow absorption from the sense of انه it keeps going in and لا انت the enteral usually you take it in after like let's say after 6 hours we expect it to be absorbed. This is the يعني it takes time to be absorbed مش انه throughout the day it's getting absorbed. طيب for IV blood transfusion 100% bioavailability the star of the show. المشكلة with IV blood transfusion is we are bringing something from من برا to inside of the body and this is a disaster. يعني احنا as much as we can we try to avoid this. We do not want to get something من برا to reach inside your body and this is the problem with IV blood transfusion IV transfusions. أنا كتبت blood transfusion شو الهبل. IV drug transfusions, this is the problem with them is that they can cause a huge amount of يعني incidence of infections and a huge amount of incidence of bleeding. طيب ولا if this wasn't the case كان تقريبا all your drugs IV يعني الصراحة يعني because it's very good يعني anything I put in your body 100% of it is gonna stay is تقريبا what I want. And why do I need that and why do we look for that? It's because of the fact that if I can 100% confirm إنه everything I give is gonna stay there, I can make sure إنه I can decrease the amount of side effects and adverse effects in the body. What do I mean by that? مثلا I give 100 milligrams of a drug to you and with my calculations I know that 30 milligrams reaches. طيب بس I have to maintain that 100 milligram. For how much should I give تقريبا؟ مثلا أنا أعطيت 100 جرام اوف ادرج 30 ملي جرام وصل بالبلد انا بدي اوصله بالبلد 100 جرام كم لازم اعطيه 300 بالضبط ف I'm giving it 300 بس كمان there's معادلة ثانية طبعا if amount of drug in your blood increases by a lot شو بيصير عندنا toxicity صح و this concept I just said is a calculation concept يعني انا calculating it فرضا وحيسكر الشحن طب يلا give me a second بس حسكر شحنه بس طيب فرضا let's say for example give me a second let me just put it in لا that's fine okay done طيب it is not working. طيب again we give 300 milligrams. Let's say for example at 200 milligrams this drug causes toxicity. يا حبيبي شو هذا؟ لأن خلاص هضغطه هيك. طيب at 200 milligrams it causes toxicity. حلو؟ how much am I supposed يعني how much am I giving this patient? 300. 200 milligrams causes toxicity. With my calculations 300 milligrams will be what 100 milligrams in his blood. بس طبعا this is in a typical patient. not يعني تقريبا not every patient is the same. There is a chance where this patient could have مثلا better absorption than other people and he gets what 200 milligrams and this can eventually cause him to go into toxicity. This is the problem with most of the drugs that are given in other ways other than blood transfusion. أو يعني through the IV blood يعني through the IV. طيب This is why كمان the drugs that we give IV are the drugs that have very low tendency to toxicity. يعني مثلا 5 milligram is how much I need for the therapy, 10 milligrams is how much it needs for toxicity. هنا مصيبة صرنا. يعني احنا دخلنا ايش؟ انه in a very worried state that I cannot maintain it except at the 5 milligram. ليه؟ Because even a little bit of increase can get him into toxicity, which becomes a disease on its own. So again, drugs that have this low threshold, and you're going to learn about it in a bit in the following lectures, this drugs with low threshold are the ones that are given شو in an IV state. طيب هون حكينا عن الموضوع intramuscular subcutaneous. اهم شيء فيها ايش؟ الفكره انه it has long releases. طيب for the disadvantages they're very يعني انه they're very شو اسمه clear. اذا حدا منكم جرب عمره intramuscular it's actually very painful. طيب وانترافينوس زي ما حكينا there is high amount of شو اسمه risk of بسم الله الرحمن الرحيم side effects اللي هي infections and blood loss. ولا if that wasn't the case we would have had IV drug use used most of the time, because again if I can confirm the amount of drug that is in his blood the whole time, if I can get that 100% bioavailability the whole time, I would for sure go for that over any other percentage. This chart is in your lecture. صراحة look at it, just make sure you understand in okay blood is the highest and then it just goes down. Intravenous reaches the peak first out of the other three اللي هي intramuscular or subcutaneous. And subcutaneous الأورال مثلا it has very low amount of absorption بس كمان it doesn't sway off يعني it doesn't fall off fastest. ف this could come as a MCQ يعني إنه حيقول لك مثلا طيب اكيد بعدين عشان نخلص بسرعه عشان ما نطول عليكم. طيب for the life cycle of a drug طيب عندنا absorption, distribution, metabolism and excretion. يعني it's very obvious. Absorption we talked about it. Distribution حتحكوا عنها بعدين. Metabolism and excretion. Yes. Oh sorry. Yeah, you're gonna get an MCQ question within this concept. يعني غالبا حيحكي الدكتور مثلا which of the following مثلا has the highest peak. طبعا ما حيحط intravenous عشان ما يلخبطكم. For the highest peak comes in what? Intramuscular, for example. يعني this is what I was saying. You know, such graphs expect in an MCQ could come in a form or way, in one way or another. طيب again absorption حكينا عنها, distribution حتحكوا عنها بعدين. It's in the following lecture. Metabolism and excretion حنمشي عليها على السريع. طيب okay. ف drugs that are weak acids, drugs that are weak bases. ف again their chemicals بالآخر chemicals are either يعني basic acid أو يعني حتى in between. طيب weak acids طيب are best absorbed where? In the stomach. Okay. Weak bases are best absorbed in intestine. This concept is very simple. هنا برجيكم بالضبط شو اللي عم بيصير يعني. طيب when a weak acid طيب meets a base or يعني an alkaline environment طيب this structure اللي هي the drug becomes ionized. يعني بتصير ايش؟ with a plus charge or a negative charge. شو مصيبة انه it became ionized؟ شو المشكلة فيها هاي؟ بالضبط it cannot cross the cell membrane. If it becomes ionized خلص ودع لي ولا عمرها it's getting absorbed. So it's gonna stay in the gut and you're gonna take it out بالحمام. يعني في الآخر you're not gonna be able to absorb it. ف to absorb such things we have to unify it with the nature that it can be absorbed in. يعني for example weak acids I have to create this drug in a way where it's gonna be absorbed when? بالstomach. وclearly احنا we know why, because the stomach is filled with acid. طب مين الشاطر حيحكي لي ليش ال weak bases are يعني absorbed in the intestine؟
intestine is base.
من ايش؟ بالضبط البنكرياس releases bicarbonate. طيب I don't know if you guys study this ولا ايش، بس pancreas releases the bicarbonate and the reason they release bicarbonate is to most of the time neutralize the acid that comes down from the stomach. The intestines are not made to tolerate the acidity of the stomach. So the bicarbonate from the pancreas helps what? Neutralize it. مع هالبicarbonate generally intestinal mucosa are more what? Basic than normal. So therefore weak bases اللي هي بالdrugs are usually شو? Absorbed in the intestines. طيب هيك احنا ايش؟ خلصنا ال2 pharma lectures. تقريبا يعني this is تقريبا everything you have to know. Very easy, very simple, very straightforward questions حيجي لكم ان شاء الله بالامتحان. We finished the mid-unit topics that we wanted to teach you guys. خلصنا.